You told your doctor about the muscle pain, the aching in your legs that starts in the morning and never quite fades, the weakness in your arms when you lift a bag of groceries. You mentioned the cramping at night, the heaviness in your thighs after a short walk, and your doctor looked at you, paused, and said it's probably the nocebo effect. Basically, it's in your head. You left that appointment feeling dismissed, maybe even doubting yourself, wondering if you were being dramatic, wondering if the pain was something you created. Well, I need you to hear something right now. It is not in your head, and the latest research proves it. Because what scientists just discovered about what statins actually do inside your muscle cells changes this entire conversation, and it has nothing to do with your imagination. I'm Dr. Richard James, and I've spent over 3 decades working with patients who take statins. What I'm about to explain is something I believe every single person on a statin deserves to hear. By the end of this video, you'll know the real biological mechanism behind statin muscle pain, why your doctor was taught to dismiss it, and exactly what to do about it, without stopping the medication that protects your heart. Here's the scope of what we're dealing with. Statins are the most prescribed class of medication in the developed world for adults over 60. Over 200 million people worldwide take them. They reduce the risk of heart attacks and strokes. They save lives. That is not in dispute. What is in dispute is this. Up to 29% of the people taking statins report muscle symptoms: pain, weakness, cramping, fatigue that doesn't respond to rest. And for decades, the standard medical response has been the same. It's probably not real. Think about that for a second. Nearly 1 in 3 patients reports a problem, and the system's answer is to question whether they're imagining it. Muscle complaints are the single most common reason patients stop taking statins. Not cost, not side effects like stomach upset, muscle pain. And when patients stop, their cardiovascular protection disappears with it. Studies show that discontinuing statin therapy significantly increases the risk of heart attack and stroke. So this isn't a comfort issue, it's a safety issue on both sides. Picture a 71-year-old retired pharmacist named Teresa, living in Tucson with her husband. 3 grown children, 5 grandchildren. She had been on atorvastatin for 5 years. The leg pain started slowly, a stiffness after walking, a deep ache in her thighs at night that woke her up. She mentioned it to her doctor. Twice. Both times she was told it was likely nocebo. So Teresa did what millions of people in her situation do. She stopped her statin on her own. Nobody listened. Nobody investigated. And that should never happen. The real question isn't just what's causing the pain. It's why the medical establishment got it so wrong for so long. That answer might frustrate you even more than the pain itself. Now, to understand why your doctor thinks this way, you need to understand where the nocebo argument comes from. Because on paper, it looks convincing. Very convincing. The nocebo effect is the opposite of the placebo effect. Instead of feeling better because you expect to feel better, you feel worse because you expect to feel worse. In the context of statins, the argument goes like this. Patients read the side effect label. They expect muscle pain, and so they feel muscle pain, even though the drug itself isn't causing it. The brain generates real physical symptoms based on expectation alone. There's a landmark trial that cemented this idea into medical practice. The Samson trial, published in the Journal of the American College of Cardiology, enrolled 60 patients who had previously stopped taking statins because of side effects. Each patient cycled through months on a statin, months on a placebo pill, and months on nothing at all. The results made headlines across the medical world. Patients reported almost identical levels of muscle pain on the statin and on the placebo. The symptom score on statin months was 16.3 out of 100. On placebo months, it was 15.4. Statistically indistinguishable. The conclusion: 90% of the symptom burden was nocebo. The pain was real, but the statin wasn't causing it. A separate trial called Statin-Wise found nearly the same pattern. Symptom scores between statin and placebo groups were too close to tell apart. These weren't small studies conducted in obscure labs. They were published in the New England Journal of Medicine and the BMJ. They involved rigorous methodology, and they told a clean, simple story. The pain is real, but the drug isn't causing it. These findings were published in major journals. They were presented at the American Heart Association's annual meeting. They reshaped how an entire generation of doctors responds to muscle complaints. If a patient walks in and says my legs hurt on this statin, the doctor now has a stack of peer-reviewed evidence suggesting the pain is psychological. Not imagined, but not caused by the drug. Here's the problem. Those studies had serious limitations that almost nobody is talking about. So if the Nocebo studies seemed so convincing, what changed? What did researchers find that the original trials completely missed? Stay with me, because the answer involves something happening inside your muscle cells right now, and it has nothing to do with expectations or psychology. Every single muscle cell in your body has a gatekeeper, a protein called the ryanodine receptor, specifically a type known as RYR1, that controls when calcium floods into the cell to trigger a contraction and when it flows back out so the muscle can relax. Think of it as a gate that opens briefly when your muscle needs to move, then shuts tightly when the movement is done. It's a precise, elegant system. Your muscles depend on it thousands of times a day without you ever thinking about it. In December 2025, researchers at Columbia University published a study in the Journal of Clinical Investigation that changed this entire conversation. Using cryo-electron microscopy, a technique that lets scientists visualize proteins at near-atomic detail, they captured exactly how simvastatin physically binds to the ryanodine receptor. What they found was striking. The statin molecule latches onto two specific sites on the RYR1 protein and forces the calcium channel into an open position. The gate that should close after each contraction gets stuck open. That means calcium leaks, continuously. Not in a dramatic, catastrophic way, quietly, gradually, persistently. Imagine a faucet in your house that drips once every few seconds. You barely notice it, but over months, it warps the wood underneath. That's what's happening in your muscle cells. Over weeks and months, that constant low-level calcium leak causes real, measurable damage. Mitochondrial stress, oxidative injury, and structural breakdown of the muscle fiber itself. The excess calcium can weaken the fiber directly or activate enzymes that slowly degrade the surrounding tissue. Then, in January 2026, a second independent team at the University of British Columbia published findings in Nature Communications, confirming and extending this mechanism. They showed that 3 statin molecules cluster together inside a pocket of the receptor, progressively forcing the channel fully open. The lead researcher described seeing, almost atom by atom, how statins latch onto this channel. This wasn't a subtle finding. It was definitive structural proof that applies broadly across the statin drug class. This is not a feeling. This is not a belief. This is a calcium channel forced open by a drug molecule, captured under a microscope at atomic resolution. Your pain was real the entire time. Now you know what's actually happening inside your muscles. Here's what should concern you next. Why didn't those big Nocebo trials catch this? The answer goes back to how those studies were designed, and it reveals a blind spot that affected millions of people. The first problem is duration. Most Nocebo trials ran 4 to 12 weeks. The Samson trial gave patients just 1 month on each treatment phase. Calcium channel disruption doesn't announce itself in week 2. It builds, slowly, over months. A slow-motion injury happening at the cellular level, invisible to anyone who isn't looking at tissue under a microscope. The studies were simply too short to detect a process that takes many weeks to produce noticeable symptoms. The second problem is patient selection. Many of those trials specifically recruited patients who had already tolerated statins without major complaint. The Samson trial enrolled patients whose symptoms appeared within 2 weeks of starting a statin, a criterion that may have biased the study toward faster onset, more psychologically driven reactions, rather than the slow-building biological damage the calcium research describes. Patients with genuine, slowly developing calcium channel disruption, the very population most likely to be biologically affected, were either excluded by design or significantly underrepresented. The third problem is the outcome measure itself. These trials measured self-reported pain on a numerical scale. They never looked at the muscle tissue directly, not once. When independent researchers performed muscle biopsies on long-term statin users, what they found changed the picture completely. Structural damage to the muscle fibers. Significant upregulation of genes related to calcium homeostasis, including the ryanodine receptor itself. Mitochondrial abnormalities visible under electron microscopy. A biopsy study involving 72 age-matched subjects found that even clinically asymptomatic patients on statins showed extensive changes in calcium regulatory gene expression in their muscle tissue. A separate study published in the Journal of Pathology found structural muscle damage in statin-treated patients who reported no pain at all, meaning the damage was there whether people complained about it or not. The cells were injured. The patients just hadn't felt it yet. The Nocebo studies measured the wrong thing, over the wrong time frame, in the wrong patients. They weren't designed to catch a biological mechanism that takes months to manifest and requires a microscope to confirm. So the pain is real. The mechanism is proven. The trials that told you otherwise had blind spots you can now identify for yourself. The only question left is this: what can you actually do about it, without giving up the heart protection that statins provide? Here is exactly what I want you to do. This is a 4-step protocol supported by the research, and you can start the first step tonight. Step 1. CoQ10 supplementation. Statins block a pathway in your body called the mevalonate pathway, which produces coenzyme Q10, a molecule your muscle cells need for energy production inside the mitochondria. Think of CoQ10 as the fuel that keeps your cellular power plants running. When statins shut down part of the production line for cholesterol, they also shut down the production line for CoQ10. When CoQ10 drops, mitochondrial function suffers, and that compounds the damage from the calcium leak. A 2025 meta-analysis of 7 randomized controlled trials found that CoQ10 supplementation significantly reduced statin-associated muscle pain. The dose supported by the research is 100 to 200 milligrams daily of ubiquinol, the reduced, more bioavailable form of CoQ10. Not ubiquinone, ubiquinol. Take it with a meal that contains fat for better absorption. Your body's ability to convert the standard ubiquinone form into usable ubiquinol declines significantly after 60, which is why the form you choose matters. Step 2. Get your vitamin D level tested. Not a guess, not an assumption, an actual blood test called 25-hydroxy-vitamin D. Vitamin D deficiency has been independently associated with muscle weakness and pain, and multiple studies show it amplifies statin-related muscle problems. A clinical study found that among vitamin D deficient patients with statin intolerance, 88% to 95% were able to tolerate statin rechallenge after their vitamin D levels were corrected through supplementation. If your level is below 30 nanograms per milliliter, ask your doctor about supplementation with vitamin D3, not D2, as D3 is more effectively utilized by your body. Step 3. Ask your doctor about switching to a hydrophilic statin. Not all statins are created equal when it comes to muscle toxicity. Lipophilic statins, fat-soluble ones like simvastatin and atorvastatin, penetrate muscle cell membranes more readily and are more likely to interact with those ryanodine receptors we discussed. Hydrophilic statins, water-soluble ones like rosuvastatin and pravastatin, are less likely to accumulate in muscle tissue. The Columbia and UBC research both suggest this molecular distinction matters at the receptor level. Ask your doctor whether a switch is appropriate for your specific cholesterol profile. Step 4. Discuss intermittent dosing. For certain statins, particularly rosuvastatin, research has shown that every other day dosing can achieve comparable cholesterol reduction while significantly reducing muscle symptoms. This works because rosuvastatin has a long half-life of roughly 19 hours, meaning the drug stays active in your system even on off days. This is not a decision to make on your own. This conversation must happen with your doctor. Do not adjust your dose without medical guidance. Those 4 steps could change everything for you. Before we finish, I need to address the one objection I hear from doctors every single time this comes up. Because if you don't have an answer for it, your conversation with your doctor will stall before it starts. Here's what some doctors will say. The Nocebo studies are definitive, the pain is psychological, and pushing back will just get you dismissed again. Here is how I want you to think about it. The Nocebo studies are not wrong, they're incomplete. They measured one thing, self-reported pain over a few weeks. The calcium channel research measured something entirely different, cellular damage over months and years. Both can be true at the same time. Some portion of reported statin pain may involve a nocebo component, That is a legitimate scientific finding. What is not legitimate is using that finding to dismiss every patient who reports muscle symptoms as if biology plays no role. That does not erase the fact that there is now a proven, biologically documented mechanism that causes genuine muscle damage in a significant number of patients. So don't walk into your doctor's office and say the nocebo effect is fake. Walk in and say this: I'd like to explore whether CoQ10 supplementation, a vitamin D test, or a switch to a hydrophilic statin might help my muscle symptoms. Can we try that before I consider stopping? That is a conversation no reasonable doctor will shut down. You're not rejecting evidence, you're adding to it. Let me bring this all together. You are not imagining the pain. Statins can and do bind to ryanodine receptors in your muscle cells, forcing calcium channels open and causing real, measurable biological damage. The Nocebo studies missed it because they weren't designed to find it. They looked at the wrong time frame, recruited the wrong patients, and measured the wrong endpoints. Here is the part that matters most. You do not have to choose between your muscles and your heart. There is a third path. The right supplement, the right statin, the right dose, and the pain can go away while the cardiovascular protection stays. You have more power over this than you probably realize. That is what I want you to take away from this video. Not fear, not anger at your doctor. A plan. A plan built on science that didn't exist 2 years ago. Remember what I said at the beginning? That the pain wasn't in your head? Now you know why I said it. Because it's not a feeling. It's not a belief. It's calcium leaking through a channel that was never supposed to be open. And now you have a name for it, a mechanism behind it, and a protocol to address it. I'm Dr. Richard James. If this video helped you understand something that nobody had explained before, subscribe, because next week I'm going deeper into exactly which vitamin protects your muscle cells while you're on a statin, the specific form, the dose, and when to take it. You do not want to miss that one. Take care of yourself tonight. You've earned it. I'll see you in the next one.